Okay, excellent. So I've only got 20 minutes, so shout out when I've only got 5 minutes left, so I give everything to you. But I think we need to understand the scope of the problem. We need to understand the definition so we're all on the same page. And then we've got to understand what the gap is so we know how to fill it, okay? We had a really interesting conversation this morning, and I enjoyed this morning's sessions about how you feel, but it's about how we feel and we bring it together. And I think that's what I hope I provide with you, with some solutions that we can take together. So Embrace, 1952, we're very lucky in this country. We've been looking at the maternal deaths in this country since then. We know the numbers have reduced, but it hasn't really budged in the past 20 years because of the change in obstetric landscape. The next Embrace report will be on the 11th of October, and in 2025 we'll be talking about preeclampsia. If you look now on my left-hand side at the bottom, you'll see the maternal deaths in this country. So to remind you, because I'm sure you all know that the dark purple are the indirect deaths, i.e. the medical problems in pregnancy, and the hatched ones are the direct deaths, i.e. the ones that happen in obstetrics because of things like postpartum hemorrhage, obstetric anesthesia. What I can tell you, having been a doctor for more than 25 years, is that your skills and drills in your maternity units are phenomenal. When you've got cord prolapse, when you've got PPEC, you know exactly what to do, when to do it, how to do it. What we've got now is that changing landscape and the medical problems, and then this actually does, make it a bit more complex. And how do we then work together? Because really, as you know, it's the tip of the iceberg. In the last time when we reviewed the maternal deaths of preeclampsia, there were 8. No woman should die in this country of preeclampsia. No woman should die of it. We should be able to recognize it, deliver, and make sure that the outcome is as good as it should be. Because unfortunately, as you both know, we cannot ensure that every baby is going to survive if they've been born too early. But more importantly, the morbidity associated with preeclampsia is striking. And as you know, worldwide, every 2 minutes a woman dies. 99% are in low-income and middle-income country. But you and I both know of every single maternal death that we may have been with in the past 20 years, myself and you. So, what am I trying to say? What I'm trying to say is that looking at Embrace, we can look at many reports, and we know the things are changing. So it's psychosocial, physical. You've got mental health, you've got the physical issues, and you've got the social aspects of the fact we live in austerity and the world has changed. Embrace identified reports when we looked at it in more detail of why is it that for preeclampsia, I'm really now concentrating on preeclampsia, what's happening, what is wrong. Where are the challenges in our communication and our leadership together, and how does this contribute to maternal death and to morbidity? And the 3 factors that we all know about, whether it's the Ockenden report, whether it's the better births, or all the reports that may have happened locally, regionally, nationally, it really is early recognition of something that's happening. Second, the prompt involvement of the right people, right senior midwives, obstetricians, and occasionally the obstetric physician. And multidisciplinary working. We've got to work together. So what is preeclampsia? And really, the definition of it has really changed, I would say, in the past 20 years. Okay, we do know that you have to have high blood pressure in the second half of pregnancy. Okay, we do know that you can or cannot have proteinuria. Proteinuria itself is not a diagnosis of preeclampsia. So don't think just because you've dipped the urine and the protein is NAD that she hasn't got preeclampsia. I love preeclampsia because it's a fantastic disease, okay? I'll be honest with you, the reason I'm a physician, obstetric physician, is because to me that's at one stage in a woman's life where she has accelerated atherosclerosis, she's as sick as she can be, and guess what? The placenta comes out and she's all right. Tell me about it. What else? What other condition in the world does that? Nothing. Okay, so I find that really fascinating because if you look at the end organ damage, and these are the blood tests that the obstetricians do, the platelets, the renal profile, the liver profile, okay, but you guys have already seen the woman and you've already decided she's got preeclampsia, and you don't need my blood test, yes, to confirm it, but let's work together. And remember, also with preeclampsia, it can be obstetric syndrome, i.e. the baby's not growing, growth restriction. So can you see that definition is far more robust now than it ever has been. But do we all have our silo thinking, fixation on something. Yes, no proteinuria, can't be preeclampsia, not worried. We've got to change our mindset because our women are changing. Placenta growth factor. Anyone heard of it? Who's using it in their hospital? Can you shout out which hospital that is? Okay. Bath. Anywhere in Wales? Not yet, okay? Because 95% of England use placenta growth factor, okay? You'll be pleased to know, with all the leadership of Marcus, I believe that we're going to have placenta-like growth factor testing in Scotland. But what are we doing in Wales, and where are we doing everywhere? Because what are we doing all the other hospitals? Preeclampsia, subjective, objective markers, and you haven't got a test that has been around since NICE have said it should be around in 2016. So what is placenta growth factor? Okay, it's a blood test that you can take. So it's a free concentration that you can take between 22 weeks and 35 weeks. Why do we measure it? So if we think about the placenta and that connection between the mum and the baby and that placenta growing, you need angiogenic markers. You need things changing in your blood vessels, in the syncytium, in the placenta, to work properly. We know in the first half of pregnancy, if the spiral arteries are not happy, you've got a higher risk of preeclampsia. And the second half of pregnancy, if these growth factors are not in equilibrium, they're not happy. And you can see from the left-hand side, my left-hand side at the top, the figure normal pregnancy. Okay, you've got the angiogenic markers, the PLGF and the S-FLIT happy. When you've got preeclampsia, you've got an imbalance of this, and the placenta growth factor is low, and therefore the blood vessels do not work properly, and you've got placental insufficiency. So wouldn't you love to have this test? Yes? Yeah. Because if it's less than 12, it's a no-brainer. She's got preeclampsia, and in this country you would, expect that she will be delivered in the next 2 weeks, and it's someone that we need to keep an eye on or possibly admit. If it's greater than 100, you're not worried, you've thought about it, but you can actually discharge her. And then the 12 to 100 is my world. It's that risk stratification. How often do I need to see her? What do we need to do? And what is the right thing to do at the right time? So, how do we approach the pregnant woman with preeclampsia? We're all working in our silos. You mentioned this morning the obstetricians and the midwives. Include me, include critical care, the ambulance service, the GP and the nurse and everywhere else that our women pitch up. Really hard, yes? But we've got to work together because we know there's guidelines, yes? We have those guidelines. But how do you maintain guidelines and who knows about it? And it's all about flatten the hierarchy. So multi-professional working, to me, is interprofessional and intra. Know your department, flatten the hierarchy and bring it together. And then more important, your woman will present in the accident emergency with the GP, upskilling them, because do they know about placenta-like growth factor? Do they know about the fact you don't need proteinuria and you can still have preeclampsia? These are really important things. So some of the ways you can learn, and today is a brilliant example of that, study days, e-learning, webinars. Which one's your fancy? Anybody? Yeah, you see, it all depends. You've got to be in the right place at the right time. Your headspace has to be there. So, study days. Action on preeclampsia, very proud to be a trustee of it, and we have study days for preeclampsia. So we have actually go across the country teaching and upskilling people to remind them of all the different aspects of preeclampsia. Days like this is a brilliant example. You're very close to Bristol, so you've got Prompt. I mean, every single one of you, I hope, uses Prompt because it's a fantastic multidisciplinary training day. But how much do we put in with preeclampsia, or do we all think we know everything about it? I would go back to your own trust and look at that. And then all our colleges, you've got your Royal College of Midwifery, you've got Obs and Gynae, and anaesthetics. I haven't even put my college, the RCP. But do we work together? Do we actually have training together? Tell me what the last time you've been to something where we've all felt welcome. Excellent. Brilliant. And I totally agree with you. So that's in regional and local, yes? But let's make it more national and international. So e-learning. E-learning is a great way. I think COVID taught us a lot, that we spend a lot of time on our computers. And when you've got the headspace, you can do this. So the multidisciplinary approaches to health is on the e-learning NHSE. It was first built in 2014 for medical SHOs. In 2020-21, we upskilled it. And then we actually realized, we needed to do it multidisciplinary. We needed to make sure midwives, obstetricians, and medical doctors could look at it. And interestingly, when we pulled which one, because it's all maternal health, i.e. respiratory, endocrinology, the one that everybody was looking at was hypertension and cardiovascular. So you can see we all want to know more about preeclampsia and cardiac disease. If we think about simulation, who likes going to a simulation? I'm not talking about prompt, because prompt is quite a safe psychological support for skills and drills. But what about other simulation days? You're all smiling. You like it? So there's 2 of you that like it. Okay, 3. Okay, I love simulation. Okay, it can be part task, it can be in situ, it can be in a day, in a whole day or half a day. And I want to share with you something that I started about 10, 15 years ago, where we got a bid and looked at simulation for South East London. And we've actually now had more than 35 training days on it. And it's called mMOET, Medical Emergencies and Obstetrics. But what was really interesting is that when we looked in detail about the behaviours of us as midwives, obstetrician, anaesthetists, because we'd have 16 in half a day, we would have 8 midwives, and the other 8 would be doctors, specialists from A&E, obstetricians, all coming together. We'd have 3 scenarios. It would, for instance, it would be subarachnoid hemorrhage, preeclampsia, and asthma. And then we would actually film and understand it. And later we would look at this recording and understand our behaviours. And what was really interesting, and I wonder whether this mirrors how you feel, that when you had a good outcome in a simulated scenario, the ones that worked well was when right at the beginning you were all on the same page. You were all working together doing something. The time when the outcome was poor clinically was when the doctor came along and just delegated all the jobs, didn't listen to the midwife, and everybody then was working in silos and not working together. Does that mirror how it feels sometimes on the shop floor? And I think this is really interesting about getting it right at the time, as soon as you turn up to a medical emergency, how we work together. That actually influences every single one of us. And what we found in this, particularly for the medical deterioration, is who's leading the team? Are you co-leading at times? It should not always be the most senior doctor or the most junior doctor. It should be a midwife at something, because everybody's a leader. Everyone has a voice and can co-lead. Secondly, developing the shared mental model. Not just thinking it in your head, speaking aloud and having the opportunity to speak aloud, so we're all saying the same thing at the same time. And then requesting and providing assistance, i.e. follow through and close communication. I'm not telling you anything that you already know, but what I'm saying to you is that when you are in that stress situation, when you're not in that normal skills and drills of a PPH or a shoulder dystocia, how do you come together to gather the information, understand it, and talk aloud? So what have I explained to you about multidisciplinary teaching and training for hypertensive disorders and preeclampsia? So if we start at the top, aspirin and pre-ET prophylaxis. So antenatally, before 16 weeks, you've got to identify that they have a risk of preeclampsia. The only prevention we've got is aspirin, sadly, in this world. I do hope we have something else in my lifetime, but I don't know. But we've got to give it at the right time, yeah? So we've got to identify it. So that's all of our problem, yes? It's not just the doctors or the midwives or the GPs. When is the aspirin given? Then if we go to the left-hand side and we go to that table, it says severe maternal morbidity. So remember, this is why women are dying worldwide and in this country of preeclampsia. They're getting eclampsia, pulmonary edema, HELP syndrome. Are we recognizing these things? Are we using the tools that we have? Are we doing the tests at the right time? Or is this a virtual consultation and the woman is not actually coming into the hospital? Once we've diagnosed it, do we use the magnesium for the right reasons, whether it's neuroprotection, preventing eclampsia, or prophylaxis for eclampsia, or treating eclampsia, and getting the drugs right? So imagine if you were on ITU and you've got somebody who's got a preeclampsia. Do you really think the intensivists understand preeclampsia? You know it much, much better. You know you want the blood pressure less than 140 over 90 in ITU or in A&E. So you have to be the voice. It cannot be the junior SHO going up there. You guys have so much more experience. You will understand this and start talking to each other. Maternity early warning score system. Is anybody using the new muse at the moment? Which hospital is that? Excellent, yeah, so are we at Tommy's. But we should all be using it, hopefully, in 2024-25, once the digital spec is out. And I would say that this is going to help us help hypertensive disorders in pregnancy, because as we know, it's from conception to 4 weeks. I know it's too far away for you to see it, but we should all be more familiar with it. But more importantly, blood pressure. If the blood pressure is high, i.e. above a 140/90 in the first half of pregnancy, finally an A&E doctor or GP or somebody might come to you and say, you know what, I'm a bit worried this blood pressure is a bit high, because you might then treat it. If you treat it in the first half, that placenta is going to be much happier in the second half, and we may have a baby that's not preterm, or more importantly, we have a really good outcome. So I think we should use the muse, and we should use this as a reason for improving our relationship with the rest of the world about hypertensive disorders in pregnancy. Clinical tips for preeclampsia. Have any of you seen this? This is the quick reference guide for obstetric emergencies, made by the OAA. They got an award in the HSJ in Manchester award last night. Commendation. They didn't win the award, but they got a commendation. But it is fantastic. So if you look up Quick Reference Guide, it has this for preeclampsia. And if you actually take this to your A&E, acute medicine, your poor junior doctor, you know, the F2 or the VTS trainee, you know, and you show it to them, look, this is how you treat preeclampsia, and you know what to give when, this will help them and it will help you. And I hope it will help the student midwives too. So please look at this. New horizons and next steps, faculty development. We've got to develop a team across maternity and all the other settings outside of maternity. Okay? We've got to work and train together. So I hope one day we will do this again, but we'll have the obstetricians and we'll have the medics here as well for half a day. You don't need them the whole day, but you can have them for half a day. And we need more research in understanding how we communicate, because we talk about culture and a change in culture. I don't think it will happen in my lifetime. We've got to understand how we're going to change that culture and work together to really, really sort it out if we want our children to have a better outcome and their offspring. So mind the gap, work to bridge the gap, and let's remain patient-centred for the rest of the day. Thank you.